We ready to go, Paula?
Yeah, it said that you have to give me permission to record.
Well, I went ahead and started to record, so we're good. Good morning, everyone. This is Dana Parsons. Thank you for joining us for the Coronavirus Weekly Call. I am excited to let you know that today is the LeadingAge National Day of Action for Older Adults. With negotiations stalled on the next level of the coronavirus relief package, we need Congress to act for older adults before they leave Washington. So we're asking all of our members to join us today and send a message to Congress. In the chat box, we have a link that you can click on. It'll take you just 2 minutes. It's a pre-written message. If you could please do that, we would greatly appreciate that. And it's also, all the information is included in your update that you received yesterday. So we have a packed hour. I'm really pleased. We have 3 presenters today. We are going to begin with Rob Liebrecht, the President and CEO of Goodwin House, talking with us today about their COVID-19 playbook. Then we're going to move into the Department of Health with Shana Bernard providing some updates for us. And then we are going to continue our conversation with Janine Fink-Boyle with LeadingAge for testing and the new CMS visitation guidance. So with that said, I'm going to hand it over to Rob. Thanks for joining us today.
Thanks, Dana, and thanks to LeadingAge overall. We're really grateful for the advocacy and the work during this incredibly important time. I wanted to just reiterate what I think we all know is that we're all in this together as it relates to the pandemic. And if there was ever a doubt about that, we operate 2 communities in particular and support a 3rd one in Northern Virginia. And although our rates are low and our cases are low at this time, because we're in counties that have high rates of positivity, we're being required to test on a much more frequent basis. And so it showcases that even when we're doing things well as members, the community around us really needs us to step forward and help make sure the community itself is being supported. So one of the key things for us was to gather all of our learnings, a lot of our learnings over the course of the last 6 months and try to put them together in a way that others could use the information. And over the last 6 months, we've had a little over 60 known cases of COVID. Most of those are with our staff. Most are asymptomatic. Most recover and come back, which is great. But we're running about a 3% positivity rate for ourselves as we look at things. And that's in contrast to the counties around us that are either 7% or 11%. So although we're low, relatively speaking, it still means that we had 2 residents in independent living that died prematurely from COVID complications months ago when this first started. And we recognize that this is just a horrible disease, virus, that we're going to have to really work together to come around. So just like many of you, we had challenges acquiring PPE. We have ongoing cost containment challenges, especially around testing. And we know the impact ongoing to our staff is significant, and it risks creating burnout as it relates to some really good people who've been dedicating themselves for years to our space. And so we want to make sure that we're doing what we can in the community. And so I want to turn it over to Lindsay Hutter, who is our Chief Strategy and Marketing Officer, to walk through and showcase the approach of paying it forward through our playbook.
Thank you, Rob. Good morning, everyone. And what you see on this first slide reflects the strategy behind Goodwin House Incorporated's approach to the coronavirus. I'm going to just quickly highlight these elements because they're the philosophical underpinning to the resource access that we'll tell you about in a moment and as we walk through the playbook. The first is that the leadership focus for us was established in about the 3rd week of February. That's when we gathered a COVID leadership team, and on March 2nd, we kicked off that team, and that team met daily up until about July. 5 days a week, every morning, we were canvassing the news, the regulations, the wonderful information and guidance we received from LeadingAge Virginia and LeadingAge National. We established early on that we would choose to be proactive, and that manifested itself in several ways. We were proactive in implementing protocols and in being very, if you will, assertive to be very safe. We were also very proactive in addressing the PPE shortage, putting together a group buy to bring many organizations together and have enough critical mass to go on the global market and buy in quantities that would be supplied by the various suppliers that were out there early on. We also had a proactive approach to testing. We began testing in May. Weren't required to test, but began testing. And we've continued that proactive approach to testing right up until today. And frankly, I don't think we anticipate changing that. We also prioritized engagement for our residents and our Good One House at Home members. And the latter are older adults that are aging in place through a life care contract program that we have. And so we knew we had to help them stay safe at home and not go out. We actually set up grocery ordering and grocery delivery programs as an example. And finally, we've had a mission mindset throughout this entire endeavor where we could share, we sought to share for exactly the reasons that Rob stated. We're stronger together, and if the region around us is safer, that makes our residents, our members, and our staff safer. So if we flip to the next slide, you're going to see two opportunities for your organizations to be part of this Stronger Together philosophy. And the first is the group buy. I mentioned that we initiated that in April, and we have continued with that. And you'll see that there is a contact email and a point of contact phone number. If you have a need for PPE, want to participate in a group buy and get better pricing and more likely better assurance of delivery, please contact the email or Holly Hanessian, who's a colleague of ours, at the phone number that's listed. Now, you'll recall that on the last slide, I mentioned we had a proactive mindset, and that also applied to testing. Very early on, through our colleague Andy Siegel, our Vice President of Business Development, and other colleagues, we established relationships with multiple testing labs. To be honest, part of this was just protection. We didn't know who was going to become a good partner, who might get overwhelmed by the demand on testing, and we wanted to have options. So we established several relationships, and we have maintained several of those relationships over time. We early on said to our testing partners, we're in this together with others. Would you be open to introduction to others? And so throughout the pandemic, we have brought other organizations forward, exercising ourselves as an access point to these testing labs. So if that would be helpful to you, again, same email, same point of contact, Holly, and same phone number. Please do reach out, and we want to be an access point because we are stronger together. Now, there was another application to our mission mindset, and you see on this next slide what is our playbook, the COVID-19 playbook. We realized that we, like you, were on the front line of COVID, and there were many organizations that went strictly to teleworking or very limited operations. But as the pandemic progressed, as school years approached, the new fall school year, we saw a variety of different types of organizations saying, how do we reopen? We had one organization that reached out to Rob. We have a board trustee who is the CEO of an organization that serves a lot of before and after school children throughout the Alexandria community. And we recognized that a lot of the content that we developed would be helpful to others. So as you can see from these bullet points, we simply took all the protocols we had, over 200 of them that we've established since the pandemic, and said, let's adapt those protocols to not be so senior living specific and in such a way that they would apply to any type of business, to a school, to a church, to a graphic design firm that ultimately wanted to bring their staff back together. And so when we started to put all of this in place, we said, we've got to have some principles for it so it makes sense to other types of businesses. And principle number one was, we're not going to splash our logo all over it, because that's going to make it seem like it's our playbook and not a templated playbook or generic playbook that they can adapt. A second thing that we need to do is very clearly say, This is our playbook. It worked for us, but you need to personalize it and make it work for you. And as I speak to all of you who are wonderful peers of ours and describe the playbook, I'd like you to think about it in two streams or swim lanes. And the first is, if there's anything in here that can be helpful to you, we want it to be helpful to you. If there is a challenge you have, and as you download the playbook and view it, you say, gosh, I don't see that challenge answered, reach out to us, because we probably have that protocol in place, and we may not have included it because it seemed to be very senior living specific. And again, when we developed the playbook, we were thinking about all variety of businesses in our region. So as you think about it for your needs, look through it. A lot of it you're probably already undertaking, but maybe there's something that's new to you, and you'd be in a position to use that and adapt it. We designed the playbook so it was cut and paste. So you literally could cut and paste and insert your specifics, your details, your situation. At the same time, that second swim lane that I'm encouraging you to think about is, what about the businesses in your region? Are you able to take this playbook and forward it to them and say, gosh, how can this be helpful to other local businesses? And we would be delighted for you to do that. Stronger Together isn't just about Northern Virginia. Stronger Together is about all of the Commonwealth of Virginia. So with respect to the actual organization of the playbook and what is the content that's in it, one of the first things that we said is, how do you prepare your facilities to be safe and stay safe? So there's a whole section on facilities, workplaces, social distancing for workers. There's another section in the playbook that's all about screening and testing. And how do you set up screening systems? What are the questions that you need to ask that are relevant for your environment, whether it's senior living in our case and in your case, or if it's some type of other business, a school, a church. We also talked about sample communications and the importance of really setting up a news engine. And I would imagine that many of you have found yourselves doing a whole lot more communications than you did previously, and on very different topics. So one of the things we did with the playbook is say, okay, what are all the scenarios that almost any business would encounter? Well, one is the communications about reopening or resuming certain aspects of our operations. How do you communicate that to your different stakeholders? Whether those are residents, whether those are parishioners at your church, whether those are students and their families. Then there are other communications when the news gets more difficult. What if you have a positive case? What if you have someone who is seriously ill? How do you appropriately communicate that information while preserving privacy? So you'll see that there are a number of communications templates that are in the playbook. Now, I want to show you a few of these so you'll see what they're like. And as we switch to the next slide, it's a sample of social distancing at work. And we first wanted organizations to do their own self-assessment, to not just say, great, here's the answer, let's apply it. Because the answers that worked for our organization may not be exactly the right answers for other organizations. So when you walk through the playbook, what you'll see is that everything leads with an assessment or a question set. What are the situations that you encounter? How many people would you need to have at work, and in what confined spaces? This is just one example that you would see in the playbook. And we also reference the importance of signage. Signage for elevators, signage for entrances, signage for screening desks. Again, a lot of things that you know being in this business, but other types of organizations that haven't been on the front line as we have and as you have might not know to think about these things. Let's flip to another slide. And this one is going to be a sample communications template. And you see it's a communications template about having someone on staff test positive. How do we convey that information? How do we convey our concern for that colleague? And then what are the procedures that we need to remind everyone because we've had a positive case, contact tracing, etc. So this is just one sample template. The other thing that's important to think about in communications, you've probably been there, and we certainly have been there, is we needed multiple communications channels, and we didn't have all of them in place prior to the pandemic. So texting, for example, we were not texting our colleagues. We're texting our colleagues regularly now to keep them updated. So we also included information and guidance on how to set up different communications channels. So if we now flip to the next slide, you'll see that this is how can you access the playbook. And I want to share with you that all of this is complimentary. There's no cost to any of it. Goodwin House is not seeking any compensation other than the knowledge that we're helping others in our region and in our Commonwealth cope with the pandemic and do it safely. So what you have here is a download. This will take you to our website. And the website place that you'll go is specifically a blog that explains and introduces the playbook and the access to resources. And at the end of that blog post, you'll see the download opportunity. Again, you're welcome to share that with anyone that you know in the field of senior living and other businesses and organizations around you. And finally, that same email, that same name, and that same phone number. If you have questions, want to participate in any of our efforts, we welcome you in doing so. That concludes my scripted remarks, other than a quick look at our overall website COVID page. We have a lot of other resources that are posted for residents, for members, for older adults, and this is all complimentary to anyone who wants to partake of what we've been able to develop. And with that, I think Rob and I would be glad to answer any questions from our audience, Dana.
Wow, thank you so much. What incredible information and such a great resource. We just can't thank you enough. I wanted to clarify the link that's in the PowerPoint can access the playbook. We also created a link to it for our update. So if you need it, it is in the chat box. It's also in our update from yesterday. Are there any questions for Lindsay or Rob?
None have come in yet, Dana.
Okay, great. Well, I just want to thank you all again. I hope that you can stay on in case any questions do arise. But everyone, you have the contact information that you can follow up with Goodwin House directly. We do have a packed agenda today, so thank you again, Lindsay and Rob. Has Shana Bernard joined us?
Hey, Dana, can you hear me?
Yes, and we have your slides ready to go. Thank you so much.
Today's the day. Man, technology is not my friend. Okay, thanks, Dana. So today I just wanted to review a new communication or notification tool that LeadingAge has created in light of the CMS routine staff testing requirements and the statement that they have about notifying the local health department. So we hope that this is going to solve some issues and be an easy way for nursing homes. So just on this first slide, I just have a little bit of the background about the language in CMS that at the end of that kind of statement that says that the facility should have documentation and then contact with their local health department. So our goals from reading the CMS language is to create an electronic form nursing homes can use to notify the health department to satisfy those CMS requirements. We also wanted to provide nursing homes an electronic response for record keeping because we know that's an important part of the CMS requirements is that documentation. So any way we could sort of easily provide that for you, we want to do. And then lastly, we also needed a system in place that we could track the number of facilities that are not able to meet these routine testing requirements. And that's going to be helpful for us to inform future planning. So you can go to the next slide. So this is just a screenshot of what the REDCap notification form looks like. These are all of the questions. We didn't want it to be lengthy in time or time consuming. The link to this REDCap survey is posted on our long-term care task force website, and it's also included in the link to this slide. So we're just asking the name of the facility, just some general demographic information. And then the yes/no questions of, do you have access to a private or commercial laboratory that has a turnaround time less than 48 hours, or do you have point of care testing? And then what the routine staff testing frequency at your facility is when you're filling this out. And then, are you experiencing an outbreak? And then that's pretty much it for what we're requiring the facility to kind of input the information for that notification. You can go to the next slide. And so once you put in that information, you know, like I said, our goal number 2 was sort of this response for record keeping. So this is a screenshot from a test form that we did that the nursing home will receive. So whatever email you put in that form, you'll get this sort of response back. And so this is a little bit of a blanket statement. Everyone will receive this. And again, this is for your record keeping. You know, due to the volatility right now with how much antigen testing supplies are going out, and also just understanding our capacity at the public health labs, right now, we're just sort of saying that we cannot provide support for the side of sort of routine staff testing. We are helping in some situations in outbreaks, and you're working with your local health departments on that. But as far as like a statewide response right now, until we know about the kind of the number of specimens, kind of where we're at with capacity, everything's sort of changing on a weekly basis. More testing technology is coming out. So right now, this is sort of our response. However, this is definitely subject to change. And we would eventually like to get to an area where we'll be able to evaluate this and have processes in place to kind of help those facilities that are in need. But this is kind of what our response is right now. And so we also include references to, you know, the CMS memo page, our testing page. If possible, even though there is sort of this out from the CMS testing requirements for staff, if you look at it and it's your turnaround time is actually 3 days instead of, you know, that 48 hours, and you're doing weekly testing, we would still encourage that you think through what is still feasible at the facility level to conduct any sort of routine staff testing, or potentially you have some point of care supplies, but not enough to test all of your staff because that definition is very broad. So maybe it's that you look at your, you know, patient care staff. So we just include that in there, that first statement of, at this point, we recommend that you continue to test your staff if feasible using your available resources. So that's just kind of what that's referring to. You know, even though you don't have that CMS requirement, we still would like you to think through, you know, what is available and what could you still kind of accomplish. Next slide. So this is a screenshot of some additional questions that will pop up in the form. However, these are not required questions. They are optional, and this is what's really going to help us kind of track the support that's needed. So we do encourage you to fill in these optional questions, but we understand, you know, everyone's sort of busy, so we didn't want to be over cumbersome with what we're asking. But if you pick that you're doing twice a week staff testing, or you're currently experiencing an outbreak, you are going to have 3 additional questions that come up. First, the estimated number of staff that will need to be tested for your sort of twice a week staff testing. And then also, if you're experiencing an outbreak, the number of residents that would need to be tested, and then the number of staff. Again, this is just an estimate. Right now, whenever we were sort of going through the support that we could potentially provide, the first question from our lab partners is always, how many specimens is this going to be? And we really don't have a great way to know that. So this is so important from planning. And if you want any support from us, this is definitely crucial for us to kind of have these numbers so we can kind of look at and see what we can support and what kind of funding and other resources are there that we could sort of match with the capacity. So again, these are absolutely optional, but we would really appreciate it. And again, it's just an estimated number. It doesn't have to be, you know, a perfect number. Just any sort of estimate will be more helpful than what we have now. And the reason that we're only asking for these 2 categories is this is where we feel like that the highest risk facilities, and where we really want to try to help out the most is in those that have a percent positivity greater than 10, and then also experiencing an outbreak. So just so you know sort of where our thought process is going, we do want to be thoughtful about the facilities and trying to necessarily help the ones that are in that sort of highest risk category. So that's why we're asking for those two scenarios. You can go to the next slide. And then lastly, I just wanted to kind of show what the response to the local health department is going to be. So this is a form that's sort of centrally kept. However, the local health departments will be getting notified as well, in addition to those of us at central office, when you fill out this form. And so this is what the local health departments will receive. They'll at least be notified that you've submitted this. And then we've also kind of added a statement in there that at this time, no further action needs to be taken by the local health department. However, we do know that there might be some local resources, or the local health department might want to follow up with you just to kind of see what's going on, or offer maybe support if you say you're having an outbreak. They might follow up with you, but that might depending on the local health department. So potentially the local health department could follow up and sort of offer more resources. However, that might not happen every single time. So I just want to let you know that the local health departments will be notified, and there is a potential that there might be some follow-up, but there might also not be some follow-up. And again, this is really going to be dictated based on what's happening in the local area, what other outbreaks they're working on, what resources are available. So that's it for my presentation. And I think maybe I just want to end with that CMS is not prescriptive in the way that they say you have to notify the local health departments or the state health department. So this isn't required if your locality wants to do something different, or if you have your own process in place at the nursing home that works for you, you can of course do that. However, we really would encourage everyone to use this. Again, we are trying to use this data to help inform future planning. And we also think that it's an easier way to notify, to kind of satisfy that CMS requirement. So we hope that the majority of facilities will be using this, because like I said, this data will be reviewed sort of on a weekly basis, so that we can better understand who's able to meet the CMS requirements and who's not. And we'll be able to kind of talk to our lab partners and others in a better way, because we'll have actual data and numbers dictating the support that's necessary. I am not on I'm only on my phone, so if there are questions in the chat, Dana, I don't know if you just want to email those to me, or if we have time. I know you said that we have a packed agenda, so that's all I have, but I'm happy to answer questions.
Thanks, Shana. There's a couple of questions, so I think we have time from. The first one is, will VDH require all private pay nursing homes to follow the CMS testing requirements?
So right now, and this has sort of been consistent, that VDH has not required sort of anything. We've had guidance out there. So those that aren't sort of fall under CMS, we would encourage them to follow the CMS requirements, but understand that there isn't that requirement piece, but we agree with the recommendations. And so where feasible, as far as staff testing, sort of think through that, create something in your testing plan, think through your resources. So right now there's no discussions on any sort of requirements from VDH for those sort of non-CMS, but we do recommend that you sort of follow those recommendations that CMS has outlined.
Great. And the second question was, how often are we required to complete this survey?
My understanding per CMS is each time that you're to do, if it's weekly or twice weekly. So if you're twice weekly, each time, twice a week, you would assess whether or not you can meet the CMS testing requirements. And I will definitely defer that. My understanding was it's, the notification is supposed to happen sort of each time. But that is also my understanding. And I don't know if that's clearly in black and white in the CMS requirements. Does anyone else on the phone have a better understanding of that?
Perhaps Janine will when she starts speaking. Shayna, thank you. That was the last question for you. They let you go off easy today.
Wonderful.
Thanks for being here. Dana, back to you.
Yeah, thank you, Shayna. We hope you might be able to stay on for the rest of the discussion, but understand if you cannot. So now we're going to move into our continued discussion on testing, as well as the new CMS visitation guidance. So thank you, Janine Fink-Boyle, joining us from LeadingAge. So over to you, Janine.
Great. Thank you, Dana. Good morning, everybody from LeadingAge, Virginia. Sorry, I have a tickle in my throat. So I'm going to talk a little bit about the visitation memo that came out end of last week, September 17th, and kind of go over some of the highlights of it. And so as everyone probably got a copy of it, hopefully you read, we did some analysis. And then if you were on our daily call on Monday, we also did an overview and talked more a little bit about operational pieces for the memo. So the memo is dated the 17th, and it's QSO 20-39-NH. So right in line, right after the testing memos. And it's focusing on visitation guidance. And so the guidance that nursing homes need to follow for indoor and outdoor visits. And then we're going to talk a few minutes also on some other areas that the memo goes into detail regarding the ombudsman and healthcare workers and activities and dining, as well as CMP funds. So before I do go right into the memo, I do want to say that we've heard from lots of states throughout our membership. And also we directed the question to Evan Schulman on our Monday afternoon call regarding a guidance that states have for visitation versus a CMS guidance, or if they're in particular phases, because some states did put in some guidance for indoor or mostly outdoor visitation. And so what CMS is stating is that they are working on making an overview so that when states have particular guidance, and it could be more stringent than what is followed at CMS, is that it's the federal guidance that is overarching. It's the federal guidance that needs to be followed. But again, that's something that will come out directly from CMS. So what I'm going to do is I'm going to go through the guidance here, and we're going to talk a little bit about all of the steps, and then potentially what could be an area of non-compliance for you if you don't follow forth what's been put in the guidance. So as we know, visitation, between March and then May and then June, CMS issued different memorandums, and then also reopening recommendations and an FAQ, all focused around visitation. And knowing that as visitors, whether family, loved ones, friends, were not able to come in and visit the residents in your nursing homes, CMS has now looked at how to have a very safe and practical and following infection control guidance, as long as also there's best practices. So what CMS put together is a core set of principles. So if you look at the memo on the second page, they have, it was about 10 core principles, and they're everything that you know that you're doing now, except obviously letting people coming into your organization. So biggest things, you're still gonna screen. So you're gonna screen everyone that enters your facility. So for signs and symptoms, and deny anyone that has any signs and symptoms of COVID-19. Obviously hand hygiene, so making sure that you have the alcohol-based hand rubs, making sure that you have it available also throughout the facility. Making sure that there are face coverings, so whether it's a mask or a cloth mask, or again, the particular PPE that you're using for your staff. Really maintaining social distance, keeping that 6 feet at least between people. So thinking about that as you're having people come into your organization and walking through the hallways, walking through neighborhoods. One of the areas that's being addressed in the memo is looking at instructional signage, because what CMS is stating is that you don't really want people who are visiting walking through other hallways, that they know exactly where they're going, so that you have your signage throughout the facility to kind of where places are, which you probably have already. But then in addition to that, looking at having signage about education about COVID-19. So whether you have posters or particular information but really kind of what the practices are. Remember to have your face mask. You know, I think everything that you see when you go into the grocery store currently, you know, maintains 6 feet and so forth. So having that signage throughout your organization as reminders to your visitors. Again, keeping up with your cleaning and disinfecting. So I know we've talked a lot about that high touch area. So now you're gonna have more people that potentially could be visiting inside your organization. So again, common routes that they'd be moving in if they're going in elevators. So you might wanna, whatever routine cleaning and disinfecting that you have ramped up, you might wanna look at that one again. Obviously using staff having your PPE. And then if you're having separate areas for cohorting, so if you have, in this case, an area that you've created that is where you have maybe positive residents, again, that you're using all of the same infection control precautions there, if you have dedicated space. And then finally, you know, the other pieces is that what Gina just talked about is that your testing procedures and your testing plan for your residents and staff. So bringing us all full circle and now looking at any of the core principles again, starting with outdoor visitation. CMS is really asking nursing homes to try to focus on outdoor visitation, knowing that you are in an outside setting, you have the ability to have lower risk of transmission because of the space and the airflow, but we know that that's not feasible. We know that it is getting, the weather's changing, and with the weather changing, you know, that having some residents might not even be able to come outside. But if you are able to do outdoor visits, that they're really trying to say that is an option that is probably, in this case, a little bit better, at least for the next, you know, in this case, hopefully month to maybe 2 months, depending if you're in Southern Virginia. But using any outdoor spaces. So if you, some of you might have seen lots of different ways to do this if you're using the parking lots or outdoor gardens, but then making sure that you have a limitation of visitors. So this limitation is something that we're going to talk about also with indoor. So as CMS put this guidance in place, what they also said is that, you know, knowing that you don't want to have 100 people coming in to visit at the same time, that you should have a, you know, reasonable limits, thinking about staggering visits, timed visits, and those timed visits at a certain time, but visits that are also then timed. So it's a 30-minute visit. We know that this also takes time from your staff too, because you still want to make sure that you are monitoring the visits, but giving people the privacy and the respect to have a visit with their families and their loved ones and their friends. But again, if there's a way to create an outdoor space using tents, any sort of plexiglass, so any of that outdoor visitation that would support safe infection prevention actions. So now indoor visitation. So the memo goes on to really outline how you could do indoor visitation. And the first and foremost is that you do not have any new on-site of COVID in the last 14 days. So looking at that's your marker. So starting today, you look to make sure that you wouldn't have any COVID cases, new onset cases in the last 14 days. Remember, this is different from if you bring in or admit someone with COVID-19. This is a new onset case in your facility. And remember, one case, so staff or resident, because you have your testing plan according to your community positivity rate, is outbreak testing. So if you're in outbreak testing, obviously, you would not be having indoor visitation. If, let's just say that that's all, you have no new cases, no new onset in the last 14 days, so you're doing indoor visitation. And so again, starting with the screening protocol, starting with making sure that there's face coverings, making sure that there is hand hygiene, so alcohol-based hand solutions, and that people are, your staff is monitoring, and that you've trained the staff to make sure that they're aware that, you know, reminding visitors to have their mask, reminding them to wash their hands, keep their social distance. Again, as I said before, with the outdoor visitation is trying to limit the number of visitors per resident at one time and the number of visitors in the building. So this is where there's a lot of coordination that you need to do if you have more than obviously one neighborhood, more than one nursing unit. And then scheduling those visits for a certain amount of time. And then the last piece is they talk again, what I said in the beginning is that limiting the movement. So again, signage is very important. I know you can't have hall monitors all throughout the building, but again, this is where the signage can really make sure that visitors know where they're going. They enter, they go down, where they're going, up an elevator, wherever they're going to the particular resident's room. thinking about if there's a roommate, to try not to do the visit in the room if that roommate obviously cannot leave the room if there's a particular medical condition. So making sure that you can attempt to not have in-room visits and maybe some other space throughout your organization to conduct the visit. And then obviously while you're checking your county positivity rate, that would then drive your visitation. So I'm gonna switch gears for a second and talk about the compliance aspect, because as this memo was put into place last week, there's not a particular F tag attached to visitation. And so like as we saw with NHSN reporting, and we saw with the CLIA waiver, with testing, that there were new F tags that were put into place under F880 for infection control. There's not a new F tag for visitation. However, CMS is pretty clear at the end of the memo talking about survey considerations. And what are they really focusing on is if you have no new onset cases for the 14 days and you are then deciding not to do visitation, that there are areas where you can become not in compliance. And so that would obviously be under resident rights. So anything that if you're limiting visitors without a reasonable clinical and safety cause, that you could actually be cited for non-compliance. That would come under the resident rights under the F550 section, so F550, F563, and then anything that they would have when surveyors could see, or any lack of infection control practices. So let's just say that there could be a complaint. Surveyors could be in your building and see a visitor, and they're not, and things aren't, and you're not following your infection control practices, that you could be cited for that. So most importantly, again, community positivity rate, what that is, which will then actually then guide if you are able to do indoor visitation. Other principles that the memo goes into talks about activities and dining. So we know that there's been some ability to have some communal dining, again, following social distancing, limiting the people at each table, allowing 6 feet apart. Again, same thing with group activities. Again, anyone that isolation for observation of signs and symptoms or suspected or confirmed, would not be a resident that should be in group communal dining or group activities. But remember that any activity that you do take, that you have to take precautions. So if there's any supplies or that someone needs to help, that making sure that everyone is using the core principles of infection prevention. So then in the meat of the memo, or the middle of the memo, I guess I should say, one area that the memo puts in its own classification is visitor testing. And so the memo is not requiring visitors to be tested. They are actually encouraging facilities, especially facilities in that medium to high threshold for positivity counties, to test visitors if feasible, but it is not required. So I want to make sure I make that point, that they are not requiring nursing homes to test visitors to come in and have a visit. So if visitors do want to bring their test results, so if they were tested within the last 2 or 3 days of proof of their negative test results, that is encouraged to visitors, but again, it is not required. The last pieces of the memo talk about the required visitation, whether it's from access to the ombudsman being able, as the resident advocate, falling under a memo that came out a little while ago. It was 20-28. Making sure the ombudsman has immediate access to residents, but then also that they have access to their medical record, and any sort of communication that the resident has with the ombudsman, whether it's by phone or any other technology, that the ombudsman does have access to the resident. And then that is obviously not just a federal reg, so that if you are not complying with that, the memo also goes into the actual F tag that you could be cited for not giving the access to the ombudsman. And I'm just trying to get that particular tag for you. I will pull it up. It is under F583. And so again, another area, not that there's a visitation tag, but there is the tag for anything related to ombudsman access. And then lastly, the memo does go into some detail about compassionate care visits and really talks about end of life situations, and not just referring to end of life as someone actually probably in their last stages of dying. But remember, there's also compassionate care situations where if you just admitted a new resident and they're maybe not getting involved in what is going on in the nursing home, and maybe they just don't have, they're kind of struggling with their new environment. That could be someone that could come in for a compassionate care visit, or a resident that might have had a family member pass away and they're grieving, or residents act one way and then all of a sudden they've declined, changed their interaction habits or their eating and drinking habits. So again, those are also some compassionate care visits where they would be consistent with the intent of a compassionate care situation. And that those visits could come in, those are also visitation guidelines that could come into your organization. So the last piece of the memo talks about some funding. So again, using those CMP funds. So we know that months ago, CMP funds were being able to be accessed through applications for technology. So it was a maximum of $3,000 in order to purchase any communication type device. So an iPad or something that you might need for residents to be able to stay connected. Well, now in addition to that, there's another maximum of $3,000 where you can apply for CMP funds to purchase any sort of physical barriers. So whether it's plexiglass or tents or something that you would need for some outdoor visitation. And so again, it's the same process that you had before, and you need to contact your state agency CMP contact. So that is the last part of the memo. I think I covered everything. I know I see lots of questions on here. And so I am gonna come up a little bit and let's get through. So hopefully I can answer some of the questions. Okay, so thank you, Dana, for putting in the memo. And I'm gonna come right past that one. Okay. So I think, so the question, I hope I answered this about expected to follow the phased plan for reopening. So that's with your state. So as I said that we don't have something directly in writing, but we understand that CMS is working with states because there are some states that are in different phases for opening, and that visitation was part of their opening regulations, guidance, or rules. And so CMS is stating that it is the CMS visitation guidance memo that will be the overarching guidance and particular rule, that is what needs to be followed. But there will be something coming out from CMS directly about that and working with your states.
Hey, Janine, I wanted to see if Kim Beasley was on and might have any comments on that. Okay, sorry. Or Shayna?
Shayna, this is Kim Beasley. Can you hear me now?
Yes, thanks for joining. I didn't know if you heard the question. Are we expected to follow the phased plan for reopening, advancing through phases, with phase 3 allowing visitation? Or are we expected to provide visitation now regardless of what phase of reopening we are in? I know this was a conversation on our task force call recently. I just wanted to see if you had any comments.
I don't have any further information. I did send the question up to CMS based on the statement in the memo, which says that it supersedes all previous guidance. So I just wanted to clarify with them that that means that, you know, the guidance we put out at the state level for the phased reopening would, you know, would not be in place right now. So anyway, have sent that up just this morning. So I'm waiting on a response on that.
And this is Shayna. Can you hear me?
Yes. Thanks, Shayna.
Okay.
Thanks, Kim.
Yeah, and just to add on to that, you know, based on, you know, what CMS says, and we are expecting that based on that statement that it supersedes. We are in the process of updating our guidance. So we are expecting to just follow the updated visitation guidance, and essentially, the phases would be, non-existent anymore. But we're, obviously working through that and still have some outstanding questions. But that is our thought process right now as we update our guidance.
Thank you. Thank you both. Sorry, Janine.
That's okay. No, that's great. Thank you. That's helpful. I'm always wondering what states have actually what they've heard too directly. So that's helpful to me. Okay, so I see there's a question about, can you refuse an outdoor or indoor visitation when a family or visitor refuses to wear a mask? Well, part of the memo actually talks about, as I said, right on page 2, the core principles of infection prevention, and one of them is face covering or mask. I am not a surveyor. I've never been a surveyor, and maybe Shane or Kim could address this. But if you're refusing that visitor, I don't know. I should say I don't think that you would be cited for not being able to have a reasonable clinical or safety cause to refuse a visitation. So I again, that's because I'm not a surveyor, but that would be how I would guide. Is that, again, it's in the, as part of the core principles to be wearing face covering or mask. Okay, so let's see. Oh, I forgot. Thank you, Dana. We did have an update when Evan Schulman was on our call on Monday. There was a write-up. Thank you for putting that in there. My understanding is that in compassionate care situations, visitors are still able to visit their loved ones indoors. Can you please confirm that this is correct? The way that I read, the way that this memo is, then I would say yes, that is correct. If you are already providing outdoor visitation, do you have to provide indoor as well? So according to this memo, yes, that this memo is effective immediately. And as you just said, this is to supersede anything that your state is doing. So you would have to provide indoor, but then again, remember, you have to have the 14 days of no new on-site cases. Can the facility require testing of all visitors? No, it's just encouraged, it's not required. Oh, sorry. We're doing outside screen porch and inside limited and not in the healthcare nursing home area. And did discuss yesterday if our area was higher, but we're already testing contract staff and care partners. I'm not sure what the question is, but again, as I said, this is effective immediately. So you need to go back to your community positivity rates, looking to have no new onset cases in the last 14 days to be able to do the indoor visitation. Oops. My question above specifically relates to if the facility is undergoing outbreak testing. Let me see. Oh, well, got that. That's a good question. So my understanding is that there shouldn't be any visitation if there is there outbreak testing. I will verify, because the way this is outlined in the memo, I see what you're saying, is that should the compassionate care visit still happen? Let me double check on that if you're outbreak testing, because my understanding, if you're outbreak testing, you shouldn't have visitation. But I will double check on that. And I think that's all the questions that are on here. Yeah.
Yes. Oh, here comes another one.
Okay. Oh. So although testing for visitors is not spelled out as a requirement for visitors, can a community make that a requirement for visitors to enter the building? We require this of staff. I would say that because the memo states that visitation does not require testing, that if you make it a requirement, you potentially could then be not complying because it's not listed as a requirement.
Janine, but a community could do it and offer it if they wanted to. Is that correct? And not make it a requirement.
They could offer it, correct, but not make it a requirement. That is correct, Dana. Excuse me.
Okay, great. I did want to raise the issue about question that we have received from a number of members about whether the Department of Social Services is going to follow the CMS guidance related to visitation. We have sent that question to DSS. I don't know if anyone is on the call and wants to respond to it, or if Shana or the OLC has heard anything to that extent.
This is Shana. I haven't heard from DSS. You know, we've been reviewing some of their guidance, and I believe that we'll probably make the recommendation that they think through what, you know, CMS is saying about visitation for nursing homes and see where that's applicable for the ALFs. I mean, I think it would be helpful to hear any feedback from ALF providers on what they prefer. You know, ALFs are variant in, you know, that category. So that's been a difficult, what we've sort of been dealing with at creating sort of ALF guidance in conjunction with DSS. So, you know, we would definitely be interested in hearing any feedback on, you know, what their thoughts are of the CMS visitation guidance and how they think they would be able to do that or not do that, because we will need to address that.
Okay, that's great. We have 3 minutes left, so I would just like to open the phone up to see if there's anyone who wants to talk about what their preference is to do in assisted living. I know this is a burning question of a number of you all, so this is a great opportunity for you to speak up, to give your thoughts about your preference as related to assisted living. And if you don't feel comfortable speaking, just put it in the chat.
And while we're waiting, you know, my understanding from DSS is that their, you know, initial recommendations were that each facility needs to kind of make their own plan. And, you know, you could use the reopening phases as a way to kind of make your plan. So I think going forward, it would be, you know, kind of review what the CMS visitation guidance says and, you know, kind of update and incorporate that into your plans. I do think if we're going away from the reopening phases in nursing homes, it doesn't really make sense to have reopening phases in ALF. So that's kind of my initial, you know, thought, but we are, you know, I want to think through this a little bit more, but, you know, we are in those sort of stages. So I really would appreciate, you know, any feedback, but I do feel like my initial thought is that we would continue saying the ALFs each need to make their own plan. But I do think that the CMS visitation guidance, you know, would be a good starting point for a lot of the ALFs to kind of look through and think how they can adopt some of those recommendations.
Thanks, Shana. We're actually, as you know, leading a work group through the governor's long-term care task force for visitation. So assisted living will be part of the discussion. That meeting of the work group is next week on the 29th. So I hope you'll be able to join us, Shana, because there'll be lots of discussion. I see there's something in the chat that says agree if they are testing regularly. So we will definitely be continuing that discussion. We are right at noon, so we really got a lot in. I want to thank all the presenters for speaking today and everybody for being on. Just a reminder, today is the National Day of Action. Please send a message to Congress. All you have to do is click this link here. It's pre-written and hit send. So thank you. Our next call will be on September 30th. At 11 a.m. and more information about that call will be included in our updates. So I hope that everyone has a great rest of their week, and thank you so much.
Thank you.
Thanks, Janine.
Have a great